I'm Dr. Radu Mihai. I'm a consultant surgeon in Oxford. I've been in Oxford since 2007, and I'm an endocrine surgeon. I do mainly thyroid, parathyroid, and adrenal surgery. I have a great interest in this specialty, and as of this October, I became the president of the British Association of Endocrine and Thyroid Surgeons, BAETS. It is a great pleasure for me to contribute to this, and I wait for questions from patients interested in discussing any endocrine condition related to the thyroid, parathyroid, or adrenal glands. Thank you. Hypercalcemia, meaning a high level of calcium, it's found many times in patients who have a blood test for an unrelated condition, unaware of any problem. So it's found as a surprise. Such blood tests are either done in the assessment of somebody with symptoms that might suggest the condition called primary hyperparathyroidism. And those people will have experienced a plethora of symptoms that come together. One very convincing symptom is tiredness, disproportionate with the level of activity, or poor sleep because of having to wake up to go to the toilet. Some patients express concerns about the recent change in mood with a tendency towards anxiety or memory loss or depression. And many patients complain of aches and pains. And all of this can be seen as just getting old and maybe are dismissed by GPs because they're so common in the population. So each of them separate might not represent anything, but when they come together as a group of symptoms, they start to be very suggestive of this condition. If in addition the patient has a history of osteoporosis seen on scans, or a history of having past kidney stones, then it's more and more suggestive to the first doctor who assessed them that probably all of this could be put together as a common cause being high calcium levels. And so the investigation starts from this type of symptoms. High calcium level can be of two main reasons. The rare occasion is a sinister scenario where somebody with advanced malignancy has a cancer that has spread to the bones, and so the bones are destroyed by that cancer, and that is in the context of very advanced oncological scenario that would be assessed already and people would be aware of it. This is the rare reason. The most common reason is to have an excessive function of the parathyroid glands. We are born with 4 such little glands, 2 on each side of the neck at the back of the thyroid. The normal size is supposed to be similar to a grain of rice, so 4 little tiny glands. And maybe 1 in 50 people have 5 such glands. And if one of them enlarges, it produces too much of a hormone called parathyroid hormone that stimulates the destruction of the bone, so that on a daily basis they lose calcium from the bone, and the more bone is destroyed, then it can be repaired. So slowly, slowly the bone weakens. So in long term, they end up with osteoporosis, and more calcium is released in the blood. From the blood, the kidneys try to remove the calcium, and so they have too much calcium in the urine, and that makes them more likely to start to develop kidney stones. And that is a very common condition, whereby the high calcium in the blood is driven by an overactive parathyroid gland. And so it happens, and so it's been observed that in the vast majority of such patients, one of the glands is faulty and the other ones stay normal. So this is why patients end up being investigated for a condition called primary hyperparathyroidism. Many patients visit the doctor not to ask about their calcium levels, visit the doctor to complain of this plethora of symptoms that seems to impact on the quality of life. Many might are picked up from the osteoporosis screening, and very few are picked up in a kidney stone clinic. So a patient who is concerned of a recent change in the strength, energy, ability, desire, engagement with life, maybe with some strange change in the memory or concentration, goes to the doctor complaining of all of this, and initially nobody's quite clear of what cause to explore for such non-specific symptoms. So it's quite common for patients to express frustration that it took a long time before anybody checked their calcium levels and before this condition has been picked up. For people in my position, it's easy because by the time we see the patients, they've already had all the results. Many of them had scans. They come already with the investigation. So the story is all of a sudden very clear and apparent, but it's not easy for the primary care doctors, for the physicians, for the GPs to just jump first at the first mention of the symptoms and say, I know this is easy, this is going to be primary hyperparathyroidism. It's not like that, and that's why patients need to be understanding of the difficulties to reach the diagnosis and to understand that it's in nobody's interest to delay finding the interest, but such is the nature of the complaints that is not very straightforward to join the two things together. A list of long type of symptoms that might not make sense with a biochemical abnormality that drives them. Diagnosis is based on a blood test. It's a simple blood test like any other blood test in which one important parameter is measured, and that is the calcium level. If that is found to be raised, the advice is to check the value of the parathyroid hormone in the blood. And if that is also raised, as one expects, you need to confirm that the patient has a normal level of vitamin D. So that's a third value that is being checked, the third blood test, the vitamin D levels. And that's because we live in a time when people don't spend enough time in the sun, there aren't enough days with enough sun, and maybe you don't expose enough skin to the sun that is out there. And so you lose the ability to make enough vitamin D in the skin. And the body responds in pushing that PTH level a bit higher in an attempt to keep your calcium levels normal. So when the PTH test is abnormal, you want to confirm that is indeed to do with the parathyroid glands and is not a normal body response to the lack of vitamin D. So such patients will have a vitamin D level checked. If it's very low, they are prescribed vitamin D replacement. They go on that sort of medication for 2, 3, 6 months and then have a repeat of the blood test. And if vitamin D level now is normal and the PTH is still high and the calcium is still high, already it's enough to confirm the diagnosis of primary hyperparathyroidism. If the abnormalities are close to the normal range and not very convincing, an extra test to check is to measure the urine concentration of calcium in the urine on a 24-hour urine sample. That was a bit inconvenient, and people didn't like the concept of having to collect the urine for 24 hours in a bottle and bring it to the GP practice or to the hospital. And now some hospitals try to create a sort of equivalent test where you just take a spot urine sample to check the calcium concentration. But the most accurate way is to put it in a 24-hour urine collection and demonstrate whether indeed there is an associated high concentration of calcium in the urine. So by the time you have this combination of results where the calcium is high in the blood, the PTH is high in the blood, vitamin D has been made normal, calcium is high in the urine, the diagnosis of primary hyperparathyroidism is made. And at that point, then the question is, can you prove what is the exact cause? Which one of the 4 glands that you have are faulty and overactive? And that is demonstrated with the scan. The scans vary depending on the expertise of each center. Most people use something called sestamibi scan, whereby this chemical called sestamibi, that's the commercial name, is injected. It's a radioactive tracer. It concentrates in the parathyroids, and then the scan tries to demonstrate whether there is increased uptake of this tracer on the right, the left, higher up, lower down, and gives you like a map once you decide to proceed with surgery. But the scan should only be done in people that are being considered for surgery. The scans are not part of the diagnosis. The scans are just an adjunct in planning an operation when the operation's been decided to be offered. Treatment for primary hyperparathyroidism, it's a matter of debate between physicians and surgeons. The main question is who benefits from an operation. And this is where the debate is ongoing. Some people feel that the condition is fairly common in the public if you look hard enough to find it. And if there are so many people who have it, then who really needs to have it corrected? And so some physicians expect that unless the calcium is very high, over a certain threshold, the value is 2.8, or if there is evidence of organ damage, meaning evidence on bone scans that the patient has osteoporosis, or evidence on a kidney scan that there are kidney stones, then there is no doubt you need to be offered treatment. While if you have a mild abnormality and maybe no clear evidence, maybe you could just be monitored. And this is where the debate comes. Why would you choose to be monitored for a condition that will progress, waiting for another 5-10 years until indeed the bones are lost enough, weakened enough, and osteoporosis established? Why would you wait to have kidney stones? Why would you wait to continue to have these non-specific symptoms that make life a misery? And this is where is this individualized decision-making, whereby the views of the medics who assess the patient, the impression of the patient of how distressed they are by these symptoms have to be balanced. So this is when a decision is made whether or not an operation is necessary. So I expect if you look at the 1 million population out there, there would be many that have no idea they have the condition. There would be quite a lot that they've been told they have a condition, but been advised to just sit on it and have repeat assessments every 6 months or once a year. And there would be only a minority that gets sent to a surgeon, such as me. And this is where the views of the public, the views of the medics, how one interprets guidelines, what are the views of those who write these guidelines, it's a matter of continuous change. As we speak, the American Society of Endocrinology is about to issue new guidance. A few years ago, NICE, the National Institute of Clinical Excellence, the body that governs our practice and gives us guidance on who should be treated and how people should be treated. So NICE wrote guidance on this condition only a few years ago. And so the topics are constantly being debated and a little bit in a change. Once you come to have an operation, you have to be referred to a surgeon. And that surgeon should be somebody with experience in this condition. Because as I said earlier, it might be a lot of patients out there that have the condition, but not many patients undergo a parathyroid operation. So there is a drive in the UK to concentrate such patients in centers with surgeons who do at least 20 cases per year. And it's not easy to put a minimum number, but 20 has been decided as a good indicator of enough experience being gained by that particular surgeon and that particular institution to be able to treat such patients. And this is something that it's a hope that will happen. And because as we stand now, a lot of the practice probably is diluted between many clinicians with experience that doesn't reach this threshold of 20 per year. There would be some units in the UK who do over 100 or close to 200 a year. Oxford, where I work, it's one of these units, but there are many other colleagues who have such volume of work. And when I say many others, will be probably less than 10 across the UK. So in each region, there would be somebody with an established experience In this region of the UK should be a hospital with enough radiology experience to help identify the position of these glands. And in each region should be a system where colleagues collaborate so that patients that seem to be more challenging would be referred to designated centers. The most challenging of all of these patients are those very rare ones in whom the tumor, rather than being in the neck, it's in the chest, for example. And that involves an operation that at times is done with the help of a thoracic surgeon. And so such is the professional development in each region, that we are all aware of our limitations, or we should be, and we should all understand of who can help with the most unusual patients.